Dear Chairman, thank you for the kind invitation to present at EBC 2021 and to Terumo for my involvement in this symposium, Mastering POT with Ultimaster. I've been asked to provide a clinical case discussion. So let's see, a 56-year-old male, in fact a medical colleague, which made decision-making slightly more fraught, presented with non-ST elevation acute coronary syndrome, preserved LV function, was found to have this significant proximal LAD lesion extending back to the left main stem. We see on multiple projections this severe disease within the proximal LAD, and this then leads to a question of whether you would nail the ostium, stent left main to LAD, consider a Lima graft, or image to then decide. And this was a polling that I placed on Twitter prior to presenting this case last year at an Indian symposium. In fact, half of those respondents suggested imaging first, perhaps partly led by the fact that I was asking the question. But we see that, some of the correspondents were suggesting nailing an ostium is unpredictable, that we certainly know that imaging studies help in terms of delineating where disease extends. Going straight to a stent, Peter O'Kane would suggest, is unnecessary, that you have to consider the imaging. Simon Ecclesall suggesting that we should be considering drug-eluting balloon. So I went about imaging without predilatation, so the quality of this run is not perfect, but actually it answers the question that I required, which is that we see disease extending back into the ostium of the left main. So we see the left main is about 4.5 lumenly. We see plaque at the ostium of the LAD. We see plaque at the ostium of the circumflex. And that very much fits with the IVUS consensus led by Gary Mintz, which showed beautifully that despite the Medina classification, that by imaging, we see that 2/3 of cases have disease that affect all three limbs. So I put out a second poll. Now we've imaged, what are we going to do? Well, there actually then was a relative split between nailing the ostium, regardless of the fact that there was disease extending to the distal left main, or stenting left main to LAD. Now, actually, the most contemporary EBC consensus would probably lean towards a crossover stent left main to LAD strategy, which was in fact what I selected. So having pre-dilated now with a 3.0 NC, we get much better appreciation of the burden of disease. I've committed to the left main, so we see extensive injury. And in fact, you see now coming back into the left main that there is actually a relative absence of dissection at the moment extending into the left main stem. But select a 38mm stent, which can be 3.5 distally, but is going to need to expand to 4.5 proximally. And it's critically important we select a device that can appropriately expand. Now, the Ultimaster Tansei absolutely has that capacity. It's a very open cell design. It offers very uniform scaffolding, and it purposefully has just an abluminal coating for delivery of the sirolimus drug. And most importantly, as I've already suggested, this 3.5 platform will, on bench, expand to 5.8, as shown by Nicholas Foyn's group. So I place a 3.5/38 Ultimaster Tansei, placing in multiple projections. I undertake an OCT at this point actually just to accentuate the issue of this pre-pot under expansion of the stent. And we see beautifully here towards the polygon of confluence how massively under expanded that stent is within the left main segment. So it's then important to undertake the pot, and there's always discussion about where to go. And again, this was another polling for the purpose of an educational presentation, which is less easy to do in this virtual world, unfortunately. But I hope you'd all agree that position D is probably preferential in terms of placing it onto the carina, so a distal placement, to enhance that apposition and open up the cells to recross into the circumflex. At this point, the OCT is used to confirm a cross of the wire, which actually was quite challenging in this example, and took multiple passes, and I never quite got as distal across as I was hoping to achieve. But ultimately, accepting the passage that I achieved, I undertook a 4.5 by 2.75 kissing inflation to clear the struts across the circumflex. and then went on actually, but due to pinching of the diagonal branch you can see in that cranial projection, to also kiss into the diagonal, again making use of this Tansei technology, which is advantageous in bifurcation. And ultimately achieved an MSA in the LAD of 7.2 millimeters squared, and in the left main of 16 millimeters squared, that really will offer the patient an excellent long-term outcome. And we see here from distal to proximal the difference made by the pot and then actually the kissing in terms of the stent coverage and the level of the polygon. So the learning, I think, from this clinical case is that there is controversy actually with a Medina 010 type anatomy. The consensus does lean towards crossover, and I've shown a nice example of where that can be efficacious. POT is absolutely mandated in bifurcation PCI, and I think stent design does play an important part in achieving good results for our patients, alongside the use of guidance by imaging to assure ourselves that we can achieve the best possible result. I thank you for your attention.